Bartholin gland carcinoma, BGC, is an uncommon malignant tumor that originates in the two paired minute exocrine glands situated at the posterior lateral margins of the vaginal vestibule. These glands are anatomically analogous to small sweat-like or oil-producing structures and are therefore sometimes referred to as Bartholin gland cancer or adenocarcinoma of the Bartholin gland. The World Health Organization classifies BGC under vulvar malignancies, and the terminology reflects both the anatomic origin, Bartholin gland, and the pathological nature, carcinoma. Precise nomenclature is essential because it distinguishes primary glandular tumors from secondary involvement by other vulvar cancers or metastatic disease from distant primary sites. Each Bartholin gland lies deep to the bulbospong sus muscle, embedded in the submucosal connective tissue at the 5 and 7 o'clock positions of the vaginal opening. The glandular acini produce a clear mucinous secretion that traverses a short duct, approximately 1 centimeter, to open onto the vestibular epithelium, lubricating the introitus during sexual arousal. Histologically, the gland comprises a secretory columnar epithelium, surrounded by myoepithelial cells and a rich periductal stromal network. Clinically, its deep location explains why early lesions may be non-palpable, and why infections or cyst formation can present as a tender labial swelling. The first documented cases of Bartholin gland carcinoma appeared in gynecologic literature in the early 20th century, around 1915 to 1920. Early pathologists noted the aggressive nature of the disease, with rapid local extension and early lymph node involvement. Over the subsequent decades, case series revealed that BGC accounts for less than 1% of vulvar cancers, yet its prognosis is markedly poorer than that of more common vulvar squamous cell carcinoma because of delayed diagnosis. The historical trajectory underscores the need for heightened clinical suspicion when evaluating persistent Bartholin area masses, especially in postmenopausal women. Molecular profiling of BGC has identified recurrent alterations in classic oncogenic pathways. Tumor suppressor gene TP53 is mutated in roughly 40 to 60% of cases, leading to loss of D and a damaged checkpoint control. HER2, ERBB2 amplification or overexpression occurs in a subset, approximately 15 to 20%, and drives constitutive receptor tyrosine kinase signaling. Additional aberrations include PI3Kca mutations, PTEN loss, and alterations in the MAPK cascade. These changes functionally resemble a broken safety switch TP53 and a stuck accelerator HER2 and PI3K, resulting in unchecked proliferation, evasion of apoptosis, and metabolic reprogramming. Estrogen and progesterone receptors are occasionally detected in Bartholin gland carcinoma tissue, suggesting a hormonal component. In vitro studies show that estrogen can upregulate secretory glandular activity, potentially providing a proliferative stimulus. However, epidemiologic data are inconsistent. The majority of BGC patients are postmenopausal, when endogenous estrogen levels decline. Some investigators hypothesize that local estrogen metabolism via aromatase activity in the perivulvar stroma may sustain low-grade hormone-driven growth, but definitive causal links remain unproven. Repeated Bartholin cysts, abscesses, or chronic dacryoadenitis create a pro-inflammatory microenvironment rich in cytokines IL-6, TNF-alpha, and reactive oxygen species. Chronic inflammation promotes DNA damage, induces epigenetic alterations, and recruits immune cells that release growth-promoting mediators. Clinical case control studies reveal that women with a history of recurrent Bartholin gland infections have a 2 to 3-fold increased odds of developing carcinoma, echoing the well-established inflammation cancer axis seen in other sites, for example, ulcerative colitis to colon cancer. Lifestyle factors that amplify oxidative stress, namely tobacco smoking and excessive alcohol consumption, have been correlated with higher incidence of vulvar malignancies, including BGC. Smoking introduces polycyclic aromatic hydrocarbons that form D-N adducts, while alcohol can impair D-N repair mechanisms. Occupational exposure to certain chemicals, for example, aromatic amines, pesticides, has been hypothesized but lacks robust epidemiologic confirmation due to the rarity of the disease. Nonetheless, clinicians should counsel patients on smoking cessation and moderation of alcohol as part of a broader risk reduction strategy. Immunocompromised individuals, particularly those with HIV and IDS or organ transplant recipients on calcineurin inhibitors, exhibit a higher prevalence of vulvar neoplasia. The impaired surveillance allows oncogenic viruses, chiefly high-risk human papillomavirus, type 16 and 18, to persist and integrate into host DNA. While the direct attribution of HPV to BGC is not as strong as in squamous vulvar carcinoma, several case series have identified HPV DNA in glandular tumors, suggesting a contributory role. Immunosuppression also diminishes the efficacy of cytotoxic T-cell responses that would otherwise clear transformed cells. Bartholin gland carcinoma most frequently arises from the secretory acinar epithelial cells that produce the mucinous fluid. These columnar cells possess a high turnover rate, rendering them susceptible to accumulating mutagenic hits. In rare instances, myoepithelial cells or basal keratinocytes can undergo malignant transformation, giving rise to mixed histologies such as adenosquamous carcinoma. The concept of a seed sprouting within the gland reflects the clonal expansion of a single altered secretory cell that subsequently invades the surrounding stroma. The p53 pathway governs cell cycle arrest and apoptosis. Loss-of-function mutations abrogate these checkpoints, allowing damaged cells to survive. HER2 amplification triggers downstream PI3K and a KT and MAPK signaling, fostering proliferation, angiogenesis, and resistance to programmed cell death. PI3K catalytic subunit mutations directly activate a KT, which phosphorylates mTOR and other effectors that enhance protein synthesis and metabolic adaptation. Crosstalk between these pathways creates a robust oncogenic network, comparable to a vehicle with both a broken brake p53 and a stuck accelerator HER2 and PI3K. Targeted inhibitors, for example trastuzumab for HER2, PI3K inhibitors, are under investigation for BGC patients harboring these alterations. Bartholin gland carcinoma typically begins as a well-defined intraglandular nodule. As it enlarges, it breaches the glandular capsule and infiltrates the adjacent vulvar skin, subcutaneous fat, and the bulbocavernosus muscle. Histologically, tumor cells exhibit irregular nests and cords with desmoplastic stromal reaction. Clinically, patients notice a firm, slowly enlarging lump that may cause distortion of the labial contour. The invasive front often shows paraneural invasion, explaining occasional pain and the propensity for early lymph nodes spread. The primary route of dissemination for BGC is through the rich lymphatic network, draining the vulvar and perineal region. Tumor cells enter superficial inguinal nodes, then progress to deep femoral and external iliac stations. Hematogenous spread, though less common, occurs via venous plexuses that communicate with the internal pudendal veins, allowing tumor emboli to reach the lungs, liver, or bone. The seed and wind analogy reflects how detached cancer cells can be carried by lymph or blood currents to distant niches, where they may establish secondary colonies. Bartholin gland carcinoma accounts for less than 1% of all vulvar malignancies and represents an estimated 0.1 to 0.2% of gynecologic cancers globally. Epidemiologic registries, such as SEER-US and the European Cancer Registry, report annual incidences of 0.2 to 0.4 cases per million women. The rarity mirrors a snowflake among many common ailments, making large-scale prospective studies challenging and emphasizing the importance of multi-center case series to refine management guidelines. The median age at diagnosis is 62 years, with a conspicuous peak between 60 and 70 years. Only 5 to 10% of cases occur in women younger than 45 years. This age pattern aligns with the cumulative exposure to genetic mutations, chronic inflammation, and the waning immune surveillance observed in older adults. Since Bartholin glands are exclusive to female anatomy, all reported cases are in women. Limited data suggest a marginally higher incidence among Caucasian women compared with African American or Asian cohorts. But the disparities may stem from reporting bias rather than true biological differences. The scarcity of cases hampers robust statistical conclusions. High-income nations with comprehensive cancer registries, for example, United States, Western Europe, report a greater number of documented BGC cases, likely reflecting superior diagnostic capabilities. Low resource settings may underreport due to limited pathology services, resulting in an apparent geographic skew that likely does not represent actual disease distribution. Patients typically present with a painless or mildly tender, firm nodule at the posterior lateral vestibular margin. On palpation, the mass feels fixed to underlying tissue, unlike a benign Bartholin cyst, which is usually fluctuant and mobile. The gradual increase in size may cause subtle distortion of the labial edge, prompting patients to seek evaluation for cosmetic or discomfort reasons. As the tumor infiltrates overlying epithelium, ulceration can develop, producing a raw bleeding surface that is especially sensitive to friction during walking or intercourse. Ulcerative lesions may exude serosanguinous fluid, and secondary bacterial colonization can mimic infectious processes, leading to misdiagnosis if not biopsied promptly. Chronic itching, also known as pruritus, arises from tumor-induced inflammation and nerve irritation. Dyspareunia results from both mechanical obstruction by the mass and hypersensitivity of the surrounding mucosa. These symptoms can significantly impair intimacy and quality of life, compelling patients to avoid sexual activity, a functional impact comparable to an annoying itch you can't scratch. Enlarged inguinal or femoral lymph nodes feel firm, non-mobile, and may be tender if infected. Palpable nodes often signal regional spread and upstage the disease, influencing treatment planning, for example, addition of inguinal lymphadenectomy or radiotherapy. Clinicians must differentiate reactive hyperplasia from metastatic involvement via imaging or fine needle aspiration. Advanced BGC can produce cancer-associated cachexia, characterized by involuntary weight loss, muscle wasting, and profound fatigue. Pro-inflammatory cytokines IL-1, TNF-alpha, and metabolic derangements drive these systemic effects, resembling the energy drain seen in chronic illnesses. A thorough pelvic exam includes inspection of the vestibule, palpation of the labia majora and minora, and assessment of regional nodes. Differential diagnoses encompass benign Bartholin cysts or abscesses, hidradenitis suppurativa, vulvar intraepithelial neoplasia, and metastatic deposits from colorectal or anal cancers. Careful attention to lesion consistency, ulceration, and fixation guides the decision to obtain a tissue diagnosis. High-frequency perineal ultrasound is the first-line tool, delineating cystic versus solid components and measuring tumor dimensions. MRI provides superior soft tissue contrast, depicting depth of invasion, involvement of the bulbocavernosus muscle, and proximity to the urethra. T2 weighted sequences highlight edema, while contrast-enhanced T1 sequences assess vascularity. CT is reserved for chest, abdomen, pelvis evaluation of distant metastases. PET-CT uses fluorine-18 FDG to identify hypermetabolic nodes or visceral spread, offering whole-body staging information that can alter management. Definitive diagnosis requires histologic confirmation. Core needle biopsy under ultrasound guidance yields sufficient tissue for morphology, immunohistochemistry, and molecular studies, while minimizing morbidity. Excisional-incisional wedge biopsy, performed in the operating room under anesthesia, provides larger specimens, allowing assessment of margins and depth of invasion. Proper fixation, 10% neutral buffered formalin, and prompt processing are crucial to preserve antigenicity for downstream testing. Immunohistochemistry, IHC, differentiates histologic subtypes and predicts therapeutic targets. p53 overexpression suggests TP53 mutation. HER2 IHC3 plus staining or fluorescence in situ hybridization. FISH confirms amplification. Chi67 quantifies proliferative index. Additional markers such as CK7, CK20, and GCDFP15 help exclude metastatic breast or colorectal disease. Next-generation sequencing panels assess actionable alterations, PI3K-CA, PTEN, EGFR, enabling personalized treatment decisions. The International Federation of Gynecology and Obstetrics, FIGO, adopts the JCCT-NM framework for vulvar cancers, including BGC. T category reflects greatest dimension and depth of stromal invasion. T1 less than or equal to 2 centimeters, T2 greater than 2 centimeters up to 4 centimeters, T3 greater than 4 centimeters, or invasion of adjacent structures. N category denotes number and laterality of inguinal femoral nodes, N0 through N3. M category indicates distant spread, M0 versus M1. Accurate staging informs prognosis and guides the selection of surgery, radiotherapy, or systemic therapy. Bartholin gland carcinoma exhibits diverse histologies. The predominant type is adenocarcinoma arising from glandular epithelium, characterized by gland-forming nests with mucin production. Squamous cell carcinoma, though rarer, shows keratinizing sheets and intercellular bridges. Adenosquamous tumors display mixed glandular and squamous differentiation, often indicating a more aggressive course. Clear cell variants contain abundant glycogen, giving a cytoplasmic clear appearance, and may be associated with HPV. Each subtype possesses distinct immunoprofiles and may respond differently to targeted agents. Tumor grade reflects the degree of architectural and cytologic deviation from normal Bartholin gland epithelium. Well-differentiated G1 tumors retain glandular morphology, exhibit low nuclear atypia, and often have a favorable prognosis. Moderately differentiated G2 tumors show increased pleomorphism and mitotic activity. Poorly differentiated G3 cancers lose recognizable glandular patterns, display high nuclear to cytoplasmic ratios, and are associated with rapid progression and resistance to conventional therapy. Grade is a key prognostic factor alongside stage. Primary Bartholin gland carcinoma originates within the glandular tissue, whereas secondary lesions represent metastases from distant primary sites, for example, colorectal and breast. Distinguishing features include the presence of an in situ component, continuity with native glandular ducts, and immunophenotypic profiles consistent with vulvar origin, CK7 positive, GCDFP15 positive. Metastatic deposits often lack a precursor lesion and may express markers indicative of the donor organ: CK20 positive, CDX2 positive for colorectal. Accurate classification avoids inappropriate surgical planning and optimizes systemic therapy selection. Surgical management is tailored to tumor size and depth. For small, less than 2 centimeters, well-differentiated lesions with clear margins, wide local excision 1 to 2 centimeters peripheral margin may suffice. Larger or deeply invasive tumors often require radical vulvectomy en bloc removal of the vulva, clitoris, and adjacent labia, with bilateral or unilateral inguinal femoral lymphadenectomy to address nodal disease. Sentinel lymph node mapping using technetium-99m and blue dye reduces morbidity compared with complete lymphadenectomy. Negative margins and nodal clearance remain the strongest predictors of local control. Adjuvant external beam radiotherapy, EBRT, delivers 45 to 50 gray to the primary site and 50 to 66 gray to high-risk nodal basins, reducing local recurrence after positive margins or nodal involvement. Brachytherapy, placement of high-dose rate, HDR, iridium-192 sources within the postoperative cavity provides dose escalation with sparing of surrounding tissues, particularly useful when surgical margins are close. Combined EBRT and brachytherapy achieve synergistic tumoricidal effects while limiting toxicity to the urethra and anal sphincter. Neoadjuvant or concurrent chemoradiation commonly employs cisplatin 40 mg per square meter weekly, exploiting DNA cross linking to potentiate radiation-induced cell death. For metastatic or recurrent disease, combination regimens such as cisplatin plus paclitaxel, taxane, or carboplatin plus paclitaxel are standard, offering response rates of 30 to 40%. In HER2 positive tumors, trastuzumab, a monoclonal antibody, is added to platinum taxane backbones, mirroring protocols used in breast and gastric cancers. Dose adjustments are necessary for renal insufficiency or neuropathy. HER2 positive BGC benefits from trastuzumab or newer agents like pertuzumab and TDM1, which block receptor dimerization and deliver cytotoxic payloads. For tumors expressing PDL1 or harboring high tumor mutational burden, checkpoint inhibitors pembrolizumab, nivolumab have shown activity in early-phase vulvar cancer trials, achieving durable responses in a subset of patients. Molecular profiling is indispensable to identify candidates for these targeted or immune-based therapies, marking a shift from one-size-fits-all chemotherapy to precision oncology. Optimal management mandates a tumor board comprising gynecologic oncologists, radiation oncologists, medical oncologists, radiologists, pathologists, and supportive care services, for example, physiotherapy. Psycho-oncology. Consensus algorithms typically start with staging. Early-stage disease proceeds to surgery plus adjuvant radiation, whereas locally advanced or unresectable tumors receive concurrent chemoradiation followed by systemic therapy. Regular multidisciplinary meetings ensure treatment sequencing aligns with evolving pathology and patient preferences. Local recurrence after primary surgery often warrants ray excision with wider margins or pelvic exenteration if extensive. Isolated nodal recurrence may be addressed with stereotactic body radiotherapy, SBRT, or surgical nodal dissection. Systemic relapse is managed with second-line chemotherapy, for example, topotecan, gemcitabine, and when appropriate enrollment in clinical trials testing, novel agents such as PARP inhibitors or antibody-drug conjugates. Salvage strategies aim to prolong survival while preserving quality of life. Prevention focuses on eliminating modifiable contributors, smoking cessation, limiting alcohol intake, and treating recurrent Bartholin infections promptly with drainage and antibiotics to curb chronic inflammation. For immunocompromised patients, optimizing antiretroviral therapy or adjusting immunosuppressive regimens can restore immune surveillance. These measures act like routine maintenance that prevents the engine, the gland, from breaking down. Women with a history of Bartholin cysts, chronic dacryoadenitis, or persistent vulvar lesions should undergo regular pelvic examinations, ideally annually, with targeted inspection of the posterior lateral vestibule. Clinicians may perform a gentle swab for HPV testing if risk factors exist. Early detection of atypical cells via biopsy can downstage disease, markedly improving survival, akin to checking tire wear before a puncture occurs. Prophylactic HPV vaccines bivalent, quadrivalent, non-avalent protect against high-risk HPV types 16, 18, 31, 33, 45, among others, which are implicated in vulvar squamous neoplasia. While the direct link between HPV and Bartholin gland carcinoma remains modest, vaccination reduces overall vulvar cancer burden and may indirectly lower BGC incidence by preventing coexistent HPV-driven lesions that could promote a permissive microenvironment. Educating women about the signs of abnormal Bartholin lesions, persistent swelling, bleeding, or ulceration empowers them to seek care promptly. Written brochures, digital decision aids, and counseling during well-woman visits reinforce self-examination habits. Routine gynecologic surveillance, including speculum and bimanual exams, creates a safety net that catches malignancies at an earlier, more treatable stage. For patients diagnosed at stage 1, tumor confined to the gland with negative nodes, 5-year overall survival, OS, ranges from 45 to 60%, with disease-free survival, DFS, around 40 to 55%. Stage 2 to 3 disease sees OS drop to 30 to 40% and DFS to 20 to 35%. Metastatic, stage 4 disease carries a grim prognosis, with 5-year OS less than 15%. These statistics highlight the critical impact of early detection on outcomes. Prognosis hinges on several independent variables. Tumor stage, higher T or N categories correlate with reduced survival. Histologic grade, poorly differentiated tumors behave more aggressively. Surgical margin, positive margins double the risk of local recurrence. Lymph node status, presence of metastasis in inguinal nodes diminishes 5-year overall survival by approximately 20 to 30%. Composite prognostic models combine these factors to stratify patients into low, intermediate, and high-risk groups, guiding adjuvant therapy intensity. Treatment can affect sexual function, urinary continence, and body image. Radical vulvectomy may impair clitoral sensation and cause dyspareunia, while radiation can lead to dermatitis, fibrosis, and vaginal stenosis. Rehabilitative interventions, pelvic floor physical therapy, lubricants, counseling, and reconstructive surgery, for example labial flaps, mitigate these sequelae. Patient-reported outcome measures, PROMs, such as the FACT-V vulvar cancer questionnaire, are increasingly used to monitor and address quality of life issues throughout survivorship. Beyond HER2 and PI3K, emerging targets include EGFR, MET, and the Notch pathway, identified through comprehensive genomic profiling of BGC specimens. Biomarkers such as circulating tumor ctDNA and microRNA signatures, for example MER21, are under investigation for early detection of recurrence and for monitoring treatment response, offering a less invasive alternative to repeated biopsies. Chimeric antigen receptor T-cell therapy, engineered to recognize HER2 or EGFR on BGC cells, is being evaluated in early phase trials, aiming to harness patients' own immune cells to eradicate tumor masses. MicroRNA therapeutics synthetic oligonucleotides that silence oncogenic MyRS or restore tumor suppressive MyRS show preclinical efficacy in reducing proliferation of BGC cell lines, representing a novel gene-level intervention. A phase 2 study of pembrolizumab plus chemotherapy for HER2-negative, PD-L1-positive BGC. A multi-center registry evaluating the efficacy of HER2-directed trastuzumab deruxtecan in HER2-amplified cases. A pilot trial of image-guided SBRT for isolated nodal recurrence. Enrollment is limited by disease rarity, prompting collaborative consortia to pool patients across institutions. High-resolution 3 Tesla MRI with diffusion-weighted imaging improves detection of sub-centimeter stromal invasion, aiding surgical planning. Robotic-assisted vulvar surgery offers enhanced dexterity, tremor filtration, and 3-dimensional visualization, allowing precise excision with clear margins while sparing healthy tissue. Additionally, intraoperative indocyanine green ICG fluorescence mapping of lymphatics facilitates sentinel node identification, reducing morbidity. Comprehensive next-generation sequencing, NGS, panels now routinely assess greater than 300 cancer-related genes from formalin-fixed paraffin embedded BGC samples. Results inform personalized regimens. For example, PI3K inhibitor alpelisib for PI3KC mutated tumors, or PIA-RP inhibitors for tumors harboring homologous recombination deficiency. Integration of tumor mutational burden, microsatellite instability status, and gene expression signatures creates a multidimensional molecular portrait that guides precision-tailored therapy.